Thank you, Giacomo and Luis. Ladies and gentlemen, good afternoon. So we'll speak about how to recognize asynchrony at the bedside. My conflict of interest is that I'm a part-time medical research manager for Hamilton Medical. So how to recognize asynchrony? Well, the easier is to observe the patient and to listen to the ventilator. If you look at the patient, you can see when the effort starts and listen when the ventilatory breath starts, and you can see if they match. In some patients, especially the obese ones, sometimes you don't see the effort and you may touch the accessory muscle to feel when the effort starts, or the expiratory muscle on the belly for the expiration. But clinical observation is limited. We can see only very severe asynchrony. If we have a delay between the effort and the mechanical breath or more than 300 seconds, you will probably see it. But if it's lower than this, you won't be able to see it. We can ask simple questions, especially for NIV patients. We can ask them a very simple question. We don't want them to talk, but they can say yes or not, and we proceed like this. But honestly, the best way to assess asynchrony is to look at the ventilator waveforms. As you know, the pressure and the flow waveforms are displayed interaction between the mechanical breath and the respiratory mechanics of the patient and the effort of the patient. So it's quite easy to see on the pressure waveform when the effort starts, when there is a change in the slope of the expiratory pressure. This means that the effort starts, and or a change in the slope of the expiratory flow. What is more difficult on the curves is to see when the effort of the patient finishes. It's not always easy, and also how much effort the patient is doing. Moreover, we have to accept that waveform interpretation is not easy and requires a training. In this study, they asked 366 healthcare providers to recognize three simple asynchrony, basic asynchrony, double triggering, auto triggering, and ineffective effort. And only a small number of these healthcare providers were able to recognize the three asynchrony. And if we look at the multivariate analysis, only healthcare providers that had a dedicated training on waveforms were able to recognize it. The experience was not important, how long they work in the ICU, or the fact that they are physiotherapists, physicians, or nurses did not account. However, in some cases, we are more comfortable if we measure a patient effort signal. And the gold standard is to use an esophageal pressure measurement, and then it becomes quite easy to see when the effort starts, when we start a negative swing in esophageal pressure, when the effort stops. So here, the effort starts here. The inspiratory effort is at the maximum here, and then start the relaxation of the inspiration, and we believe that the mechanical breath should stop in the mid-range of relaxation. But we can see also how deep is the effort, how important is the effort. Then if we don't have esophageal pressure, we can also use the EMG of the diaphragm that can be measured either with an esophageal catheter, using the NAVA catheter, or with surface electrode. But honestly, surface electrode is not so easy. There is a lot of noise, so it's good for research, but for clinical use, it's quite difficult. This recent study compared the number of asynchrony detected only looking at the flow and pressure waveforms or using the EMG of the diaphragm. And for most of the asynchrony, when we use an assessment of the inspiratory effort, then we are more precise and we find more asynchrony than using only the pressure and the flow waveform. This is true for auto-triggering, double triggering, premature cycling, and late cycling, but it's not true for ineffective triggering. Ineffective triggering is much more detected by the flow and pressure waveform. So we will discuss a little bit about reverse triggering, and then the phase asynchrony, the flow asynchrony, and then we describe some associated asynchrony. So reverse triggering was already mentioned by Luis. It's a passive inflation that induces an inspiratory effort in a repetitive and consistent pattern. It occurs in patients that are heavily sedated, and honestly, it's very difficult to recognize clinically. So we need the waveforms. We can suspect it with a distortion of the pressure and flow waveform, but most of the time it's easier to see it if we have an esophageal pressure. This is an example of a patient that is heavily sedated and paralyzed, ventilated in volume control. So this is the flow, the pressure, the esophageal pressure, and the transpulmonary pressure. As you see, the patient is fully passive, meaning that at each breath there is a positive swing in esophageal pressure. The same patient, we stop myorelaxant and keep deep sedation, and you see on the esophageal catheter negative swing occurring from time to time, meaning that the patient is doing some inspiratory effort. And these inspiratory efforts are associated with a quite high transpulmonary pressure. So how does it look, reverse triggering? If we zoom in volume control, it starts always with a ventilator-triggered breath. So we have a square flow and an increase in pressure. And at some point, you see that there is an inspiratory effort of the patient that is quite deep and is able to trigger a second breath. So the patient gets 2 breaths without expiration in between. In pressure control, it's the same. It starts with the ventilator-triggered breath, the pressure increase, and at one point, you see that the patient has an inspiratory effort that will trigger a second breath. What is the risk? It was already mentioned by Luis. The patient gets 2 tidal volume, so at the end of the day, it's a large tidal volume. Then in some instance, like here, the transpulmonary pressure will increase. And if you want to measure plateau pressure or driving pressure at this point of time, of course, the measurement will be wrong. What asynchrony do we find in pressure mode, in pressure support and pressure assist control? First, the phase asynchrony that can occur either at the initiation of the mechanical breath or at the end of the mechanical breath, or the flow asynchrony that occurs during the mechanical breath. So the first phase asynchrony is auto-triggering. Auto-triggering is quite common, especially in NIV with unintentional leaks. It's a mechanical insufflation without an inspiratory effort. How can we recognize it? Well, you will see a high respiratory rate on the ventilator, which doesn't match to the respiratory rate of the patient. It's very uncomfortable, so you will see it in NIV. Or you can ask the patient, does the ventilator give you a breath when you don't want one? Why do we get auto-triggering? It is caused by unintentional leaks in NIV, water or condensation in the circuit, cardiogenic oscillation, and of course, a very sensitive inspiratory trigger sensitivity. So, if you have an esophageal catheter in place, you can see that this breath was triggered by the patient because you see a negative swing in the esophageal catheter. And the second one, reversely, there is no negative swing, so the second breath is auto-triggered. If you don't have the esophageal catheter, the esophageal pressure, you can suspect it because you won't see the decrease in the pressure just before the mechanical breath. It will be flat. And also, you will see that the maximum inspiratory flow is reduced just because the patient is not doing an effort. And you will see that the inspiratory time constant is different between a patient-triggered breath and an auto-triggered breath. This is especially true in NIV because the resistance of the airways are higher when the patient is not doing an inspiratory effort. So you can recognize or suspect it even if you don't have esophageal pressure. Sometimes you may see several auto-triggered breaths in a row. This occurs quite often in NIV when we have unintentional leaks. Inspiratory trigger delay is a delay between the patient effort and the mechanical insufflation. You can see it by observing the patient only if the delay is long enough, or you can ask the patient, is it difficult to get the air? Why we have inspiratory trigger delay? Again, because of unintentional leaks, because of a low inspiratory trigger sensitivity, or because of intrinsic PEEP with an inadequate setting of external PEEP. How we can see it on the curve. On the curve with esophageal pressure, you can see exactly when the effort starts and when the mechanical breath starts by the increase in pressure, and you can measure this delay. If it's more than 200 milliseconds, it's inspiratory trigger delay. If you don't have esophageal pressure, you can also, most of the time, see when the effort of the patient starts and when the mechanical breath starts, and you have to measure the delay. Now, ineffective inspiratory effort is a step forward. It's more severe than inspiratory trigger delay. It's a patient inspiratory effort which does not trigger a mechanical insufflation. And it was mentioned already that it's one of the most common asynchrony in intubated patients. How we can identify by observing the patient, or we can ask the patient, does the ventilator give you a breath? Each one you want one. And as it was demonstrated by Louis, clinically, usually the patient don't realize that they have ineffective effort, and at least they don't complain about it. Usually there is no discomfort associated with this asynchrony. Why do we have this? It's the same reason than a delay inspiratory trigger, low inspiratory trigger sensitivity, intrinsic PEEP with inadequate setting of PEEP, and usually this is also associated with over-assistance, meaning that if pressure support is too high, the drive is decreased, and this is a risk for ineffective inspiratory effort. How you will see it? Well, if you have an esophageal catheter in place, it's very easy to see that there is a negative swing without a mechanical breath. But if you don't have it, you can suspect it when you see during the expiratory flow a sort of distortion to the baseline, and also on the expiratory pressure a distortion to the baseline also. So if you have both signals here, here, and here, these are ineffective inspiratory effort. Let's move to the cycling asynchrony. So at the end of the mechanical breath, what can happen? Premature cycling means that the duration of the mechanical breath is shorter than the duration of the patient effort. You can see it by observation, or you can ask the patient, is the breath too short? This is quite uncomfortable, especially in NIV. Why do we have this? Because we set a short expiratory trigger sensitivity, or if we are in pressure assist control, because we set a short inspiratory time, or a short TI max if you have these settings on your ventilator. It's often associated with a strong inspiratory effort. So here again, the normal, the good synchronization occurs when the mechanical breath stops in the mid-range of the relaxation. In this case here, you see that the mid-range of the relaxation is here, and the mechanical breath is much earlier, so this is a premature cycling. If you don't have esophageal catheter, you can also suspect that there is a premature cycling here, because you will see that the inspiratory or insufflation time is shorter than normal. You will see also that the peak expiratory flow is lower than a normal breath, and you will see this distortion of expiratory flow at the beginning of expiration, meaning that the patient is still doing an inspiratory effort, and it means that the inspiratory effort stops somewhere by here. Double triggering occurs also when we have a premature cycling. It's two mechanical insufflation triggered by one single patient inspiratory effort. So you can see it by observing the patient. You can ask, does the ventilator give you 2 breaths? And what are the reasons for double triggering? Again, a high respiratory drive, a low pressure support, a short expiratory trigger sensitivity setting, or a short TI or a short TI max. If you have an esophageal catheter, you will detect it. The effort of the patient starts here and stop here. And when the first mechanical breath finish, the patient is still in inspiratory effort and is able to trigger a second breath. Honestly, you don't need to have esophageal pressure to see it because it's quite visible to see it as on the pressure waveform or on the flow waveforms. Late cycling is a mechanical insufflation that is prolonged during the patient expiration, so it's reverse as premature cycling. You can detect it because it's by looking at the patient, and late cycling is a very uncomfortable asynchrony. Or you can ask the patient, do you feel you can breathe out correctly? Why do we get late cycling? Because we set a prolonged expiratory trigger sensitivity, or because we have unintentional leaks in NIV. And here, again, a good synchronization is displayed here. Here in this case, the mid-range of the relaxation is here, and you see that the mechanical breath is prolonged after the end of the patient effort. You can suspect it on the pressure waveform when you see at the end of inspiration a rise in pressure, which usually means that the patient is stopping the inspiratory effort or even starting to have an expiratory effort. Be careful, there is a small pitfall. If you have a patient with a very strong inspiratory effort, the relaxation of a strong effort may create by C this small increase in pressure, which does not mean that it's a delayed cycling. So this is just a difference. To finish, I will mention flow overshoot. So what is a flow overshoot? Is that the flow provided by the ventilator is higher than the patient needs. So you can identify it because it's very uncomfortable, or you ask the patient, do you get a blast of air? Why do we have flow overshoot? Because we set a too high pressure support or a too short pressure rise time. How can we see it? We don't need esophageal pressure to see it. We will see a pressure overshoot at the beginning of insufflation and a flow overshoot here. This flow overshoot may disturb the expiratory, the cycling, because you know that the cycling criteria conventionally is a certain percentage of the maximum inspiratory flow. The reverse is a flow starvation, which is that the flow provided by the ventilator is lower than the patient needs. You will see it because the patient will be uncomfortable, or you will ask, do you need more air? Why do we have flow starvation? It's reverse because the pressure support is set too low, or we set a long pressure rise time. How do we see it? If we have an esophageal catheter, of course we see a very strong and deep inspiratory effort, but you will see it also on the flow waveforms. Instead of having a sort of triangular shape, here we have a rounded shape, meaning that the patient is pulling all along insufflation. So if you see this rounded shape like this, you may suspect that there is a flow starvation. In volume assist control, this is also very important. In volume assist control, we set a fixed inspiratory flow, and usually, if the inspiratory flow is correct, the rise in pressure is linear. Here you see in this case it's not linear, but there is an upward concavity, meaning that the patient is doing an inspiratory effort during the breath, which usually is caused by an insufficient inspiratory flow. So in this case, at least we should increase the inspiratory flow, but it's very difficult to match the patient need all the time. So maybe the best, as it was discussed before, is to changer mode for a pressure support mode. Associated asynchrony, if we have, for example, an inspiratory trigger delay, most of the time this will create also a late cycling. Meaning when we are late to start the mechanical breath, we are usually late also to finish the mechanical breath. However, the reverse is true. If we have a late cycling, this can induce or worsen intrasec PEEP and also induce an inspiratory trigger delay. So it's a sort of vicious circle, and it occurs mainly when we have high pressure support and unintentional leaks. And the way to manage it currently is to use a very sensitive inspiratory trigger setting, to decrease pressure support, to limit unintentional leaks, and to shorten the expiratory trigger sensitivity. This is showed here, a patient with an inspiratory trigger delay, and that is reported with an expiratory trigger delay. And because there is an expiratory trigger delay, the patient activates the expiratory muscles. So it's not that good. Here, it's even worse. We have a late cycling that probably worsen dynamic hyperinflation, and right after this, we have an ineffective inspiratory effort. Sometimes you have also complex asynchrony. This is a case where if you look at the pressure and the flow waveforms, it looks like a double triggering. So you may say, well, okay, the ETS is not properly set. I should prolong it and I will solve the problem. But if you look at the esophageal pressure, well, it's different. You see that the first breath is not triggered by the patient. There is no inspiratory effort. It's a passive breath, meaning that the first breath is auto-triggered. And interestingly, this auto-triggered breath induces an inspiratory effort of the patient. So it's a sort of reverse triggering occurring in pressure support. I'm not sure that we should call it reverse triggering, I don't know. But in this case, if you don't have esophageal catheter, you are not able to detect what is a problem. So to conclude, the detection of severe asynchrony is clinical, but clinical examination have some limitation. So it's useful to use the waveforms and also, if possible, to use a signal of the patient effort. It will be even more precise. Detection of asynchrony requires a training, and it's a full-time job. I mean, you could walk around your ICU and detect asynchrony in all your patients. And by the way, you come to the same patient, there will be other asynchrony because now it's the night or the morning or whatever. So it's impossible to optimize this all the time in all the patients. And also there is a limitation. We use fixed setting for pressure support, inspiratory trigger, and expiratory trigger. So it's impossible not to have asynchrony. So that's why, for me, the only solution is to use a sort of closed-loop adjustment of inspiratory trigger, expiratory trigger, and pressure support in order to try to solve this problem as much as possible. Thank you for your attention.